Welcome, everybody, and on behalf of bioMeriU, thank you for joining us today. I'm Steve Walker, and I'll be moderating today's webinar about how to enhance responses to sepsis in the critical care setting. It's my pleasure to introduce the expert leading this session, Kirsten Springer. Mrs. Springer is a staff nurse, and she's the sepsis coordinator at Mission Hospital Surgical Neurotrauma ICU in Mission Viejo, California. Her experience has cultivated insights on the role of nurses in the ER and in critical care settings when diagnosing sepsis patients, including how to incorporate and optimize PCT. As part of our discussion today, having led change within her own hospital, Mrs. Springer will explain the need to challenge the status quo in order to encourage quality in the ER and in the critical care setting regarding response to suspected sepsis. And as you'll soon hear, Mrs. Springer brings a great deal of enthusiasm and energy to the topic of sepsis. Her description of the sepsis code, which is a protocol to hasten the pace of sepsis diagnosis and save patients from preventable tissue damage, multiple organ failure, and death, is extremely timely. According to the Centers for Disease Control and Prevention, sepsis is one of the 10 leading killers of Americans, and the Sepsis Alliance notes that sepsis is the third most deadly disease in America today. Aside from the extreme morbidity and mortality caused by sepsis, the cost to the U.S. healthcare system is enormous. So Mrs. Springer will spend the next 30 minutes or so exploring quality imperatives when monitoring for and treating sepsis cases. So with that, I'll turn it over to Mrs. Springer.
Thank you kindly for lending this opportunity to share my experience. This is my personal experience with PCT, the ED, and critical care nursing. I've been involved from the beginning of the Surviving Sepsis campaign. I live, eat, and breathe sepsis, and I 100% believe in its efficacy. Even if you do it poorly, your patients will still be better. Most facilities nationally are finally seriously looking at sepsis, so I'm hoping that today's webinar will help that a little bit. There is the current FDA claim that the VITAS BRAMS PCT is an automated test, and it's intended for use in conjunction with other lab findings, and that's important to remember, and clinical assessments to aid in the risk assessment of our critically ill patients on their first day of the ICU admission and for progression to severe sepsis and septic shock. It's one piece of the puzzle. The IHI noted in their white paper that as of 2003, there were 1,739 U.S. hospitals in the IHI comparative database, and they showed that they exhibit a 450% variation in patients' chance of dying, and that is ever true in terms of sepsis. We can certainly do better. Why is the mortality rate for trauma, STEMI, and stroke 4 to 8%? It's not because they're not critically ill. It's because they have standardized, multidisciplinary, protocolized approach that they do over and over and over again. And we all know nationally that sepsis has a wide variation in how we care for those patients. This used to be the face of sepsis, and at Mission Hospital where I work, we have not seen this in 2.5 years that we've had our sepsis initiative up and running. You just do not see it anymore. The status quo is gone. We completely do it different, and it's really through these evidence-based standardization of care practices that we've been able to come away from this. Fortunately or unfortunately, however you look at it, the efficacy of your sepsis initiative is dependent on your ability to create a house-wide implementation. I will tell you, if you concentrate on quality, the cost will follow, but if you do not focus on a house-wide initiative, you're going to struggle. It's the ED is imperative. My ED staff at Mission, they are experts with sepsis care currently, but it took us 2.5 years to get there. We started out with a very modest program, and we've nickeled and dimed ourselves throughout the last 2.5 years. And our ED is certainly, I would call, experts at this time. Let's just have an agreement on what sepsis is. We have to have a systemic inflammatory response. And we have to acknowledge that we have a systemic inflammatory response. So often as nurses, especially in the ED, we can consider our heart rate elevated because of pain or because of anxiety. But when you take a step back and you look at a combination of physiologic variables that, when combined, are the big red flags that we have that systemic inflammatory response syndrome. That's how we're able to effectively actually diagnose. So let's have an agreement. And by the way, in my opinion, this is 2010 information. I believe by 2015, the whole sepsis campaign will have changed. We are only in the beginning of this very long process. So for currently 2 or more of the following create a positive SIRS criteria. So most of the time they're febrile. We know that older patients don't have fevers, and we know immunocompromised patients don't have fevers. So they're febrile, they're tachycardic, they're tachypnic, and they have white cell changes. And really we want to look to the bands as the most important part of those white cell criteria. So we have serious infection. It's diagnostic of sepsis when you have infection plus SIRS criteria. Those patients can go to the floors. It's when you have the associated organ failure. Do you need the whole sepsis initiative, early goal-directed therapy that needs to go to ICU, and septic shock. We know that SIRS is present in burns, trauma, sterile pancreatitis, but when it's combined with an infection, that is by definition severe sepsis and septic shock. I'll give you a second to read this. It doesn't matter in what order the letters in the word are. The only important thing is that the first and the last letter be in the right place. The rest can be a total mess, and you can still read it without a problem. This is because the human mind does not read every letter by itself, but the word as a whole. And for me, this slide depicts the emergency room. Nurses are able to look at chaos and make sense of it, just like we're able to read this slide. It is truly chaos in the emergency room. I'm a critical care nurse, but I know, I'm in the ED every single day that I work as a sepsis coordinator. It is chaotic, but we still need, amongst the chaos, to really look at our patients and look where they were in triage, where are they now, where are they going, in order to properly assess how our patients are diagnosed and treated for severe sepsis and septic shock in the ED. In my facility, part of the sepsis initiative is we actually call a code sepsis in the ED. Just like our code STEMI, code stroke, and code trauma, we do call code sepsis. In the beginning, it was kind of thought of as just a little bit of an overkill, but I believe, and we know, the sepsis mortality rate is higher than the other 3 disease states. It needs to be treated accordingly. And code sepsis allows us to bring the care to the patient. Our rapid response nurses actually respond to code sepsis in the ED. The rapid response nurses actually go to the ED. But how do you diagnose code sepsis? You have to actually call it code sepsis. That's the other reason why I like code sepsis, is forces the diagnosis, because you cannot diagnose what you do not treat. So inquiring minds to know, how does one diagnose sepsis? Well, we've kind of gone over that. And ask yourself, does the patient have to look deathly ill? And actually, no. We know that 75% of severe sepsis patients with high lactates don't actually look ill. So maybe they have a little bit of mottling at the knees, but many, many times they're hyperdynamic. They have that, for those of us who are old in the audience, they have that warm shock, the dry shock, that hyperdynamic state. They don't look cold and clammy like the CHF patients. They don't look like cardiogenic shock patients that are wet and cold and shocky. They actually don't look so bad. Their little cheeks are pink and they're warm and dry, but they are still in shock. So remember, you cannot treat what you cannot diagnose. So that's our code sepsis. It forces them to put the pieces of the puzzle together, looking at the labs, the acid-base balance, organ dysfunction, current therapies, vital signs, comorbidities, perfusion, and trending. Certainly, the procalcitonin as part of your lab armamentarium can help you diagnose an actual bacterial infection. If you have that lower respiratory tract infection, how do you know if you have a viral syndrome or you actually have a bacterial infection? How do you know when to start antibiotics? Well, we know once we've diagnosed sepsis as infection plus SIRS criteria, we now have to look at organ dysfunctions, acute, not chronic. We have to find out. Look at them. Do they have altered LOC or confusion? Do they have respiratory dysfunction, cardiovascular? Certainly, I think hepatic or shock liver is underdiagnosed with sepsis. I see that all the time. It's barely mentioned, but their total bilis up and their LFTs are up. Oliguria and elevated creatinine, and then, of course, your hematologic. So looking at these acute, not chronic organ dysfunctions can certainly help you determine that they have actual severe sepsis. We can prognosticate in the ER by looking at our patients what our mortality rate was. Derek Angus did this in 2001. He replicated these data in 2005, and I, at my previous facility, replicated these data with my personal sepsis database of 450 patients. I currently have about 259 in my Mission Hospital sepsis database, but I replicated these exact data. 20, 40, 60, 80, 100. And the ED nurses, you need to look at your patients and say, you know what, I have altered LSC, my patient's confused, their tachypnea with increased FiO2 requirements, their blood pressure's, in the 80s. We have a 60% mortality patient here. And yet when the trauma is called, all the staff run to the trauma. And so we know that these patients are certainly, they need more attention in the ED. But how do you really know that you have a sepsis patient? Who are these people? We have very common sources. Certainly our chest-infected patients, the pneumonias, aspiration pneumonia. I did a quick query on 5070, the ICD-9 codes for pneumonia, and I'm telling you, half our ICU patients had an associated aspiration pneumonia. The acute abdomens, all the perforated bowels, our abscesses that are sometimes misdiagnosed in the ED. I had a patient with a liver abscess that they thought it was a new cancer, and they completely missed that patient. He went to the regular floors, decompensated on day 2, and went to ICU with multi-organ failure because they thought it was a cancer, not an abscess. Cholecystitis, those patients can be very, very sick. The pancreatitis patients, 10% are actually infected. The UTI patients, fully associated UTIs, our pylos can be very, very ill. Any post-surgical wound patient can become septic to cubes, cellulitis. We've had 3 spinal abscesses come through the ED in the past 2 years. Those are certainly interesting cases that started out with just a skin abscess. Central line-associated blood sepsis infections, meningitis, SBEs, and of course in the critical care unit, all of our critical care patients have a risk of that translocation of the bacteria across the gut associated with ARDS. And we need to always be aware that those patients can turn into severe sepsis, septic shock. So here's our bundles. We have resuscitation bundle and our management bundle. So all you ED nurses, your 6-hour bundle is the resuscitation bundle. And the big Surviving Sepsis Campaign article was just published showing that in terms of the overall rate of CVP greater than 8 within 6 hours, nationally it was 34%. So we have a long way to go for that early diagnosis. Really 34% nationally with 15,000 patients in their database. Only 34% were accurately diagnosed and treated within those 6 hours. So that's only 34% of the total population of severe sepsis that actually got that bundle element met. So let's agree, we have lactate, blood cultures prior to antibiotics, early source control. You notice source control is not a 24-hour bundle element, it's a 6-hour bundle element. Broad-spectrum antibiotics, again, 2 hours to diagnose, 1 hour to infuse. For hypotension or lactic acid over 4, we want to give that initial 20 mils per kilo, about 1.5 liters. Certainly most ERs are now giving up to 8 liters, but certainly initially it's that 1.5 liters. And then vasopressors not responding to fluid resus. Remember, treat these patients like trauma or burns. We want to give the fluid resuscitation first before the pressors. And then for persistent hypotension, despite fluid resus, that's where we're going to put in that CVP and get it 8 to 12 for non-intubated and 12 to 15 for intubated, and watch that low urine output. Grab those SCVO2s. If you don't have that preset catheter, just do serial SCVO2s and utilize blood products to keep those crits up. For the management bundle, we want to look at low-dose steroids for septic shock. So if your patient's on pressors and you cannot get them off pressors, they failed a reduction in pressor dosing. Then we can use those low-dose steroids, Surgicogen alpha activated, screening, glycemic control, less than 150, although my facility is up to 180 on that now after the NICE study. And then our low tidal volume ventilation, the gold standard for lung protective strategies. In terms of clinical definition, it's certainly more difficult without that single tester marker. And I recently started utilizing procalcitonin about a year ago. But really, for the first 5 years that I was doing the sepsis initiative, we had no lab tests. And I've been reading about procalcitonin since early on, hundreds and hundreds of articles, and I was so excited when I finally got PCT because I finally had a lab test. Everyone thinks that lactate is the lab test for sepsis. Lactate has nothing to do with infection. All it tells you is that you're in shock. In terms of I work in a neurotrauma ICU. In terms of acute intracerebral bleed, we can grab a CAT scan. For malignancies, grid look to the pathology. For our MIs, we just grab those CPKs and troponins. And for trauma, of course, if we're looking for fracture, we just look for radiology. And so with sepsis, there wasn't that actual lab test. There are options available, and I have been utilizing procalcitonin for about a year. What is procalcitonin? It's a prohormone of the hormone calcitonin. It's produced by several cells in your body and many organs in response to the pro-inflammatory stimuli, in particular bacterial products. The normal is less than 0.03, and it's usually not elevated by viral infections, colonization, and autoimmune diseases, and this is huge. The procalcitonin increases within 2 to 12 hours post-bacterial infection. So if in the ED your first PCT is low or negative, know that second PCT about 6 hours later would be a good idea because it does not increase for 2 to 12 hours. Think of it like you do our MIs, where we have our serial cardiac enzymes. The PCT does have a half-life of 12 to 24 hours. And I will tell you, when you first put out a PCT at your facility, it's imperative that these details are educated to your entire staff, physicians as well as your nursing staff, because the devil is in the details. And if the details are not properly described to your staff, there can be some misinformation and miscommunication and misuse of procalcitonin. You can trend it over a 6-day period. So I really want to emphasize the importance of the details of procalcitonin early on when you're putting out PCT to your staff. There are some caveats. Multiple traumas, major surgery, severe burns, or neonates can have elevated PCTs, but return to the baseline can be rapid. Remember, the half-life is only 12 to 24 hours. And I think this next bullet point is very exciting, that PCT times 2, 6 hours apart, has a 95% negative predictive value. So that's huge, just like those cardiac enzymes. In terms of pancreatic diagnostic assistance, it can certainly help to determine whether it's infective versus sterile. And plasma levels rapidly fall as the inflammatory activity regresses. So I actually have seen a PCT level of 100 go down to less than 5 within 24 hours of a patient that started out with multi-organ failure, but due to our excellent care here at Mission, was able to get that patient turned around very, very quickly. And those PCT levels did reflect that. I think it's important that with relevant bacterial infection, the PCT is produced and released into the circulation from the entire body. C-reactive protein is a response from interleukin-6 that goes to and is made in the liver and released into the bloodstream, whereas procalcitonin with sepsis is actually made by multiple organs and tissues throughout your body. I think that's really important to know. This is Bone and Colleagues. This bone classification just shows that you can kind of look to severity of illness and your PCT levels. And this kind of depicts that with no sepsis, these 22 patients had very low levels. With sepsis, with those 96 patients, had moderate levels, and then it continued to increase in terms of severity of illness. And this slide shows the same thing. This was Chris Crean and colleagues, and he also showed that the higher the level of PCT, the severity of illness did continue to increase. In terms of comparison with procalcitonin, this, I think, is important to realize that the specificity and sensitivity with PCT is higher than with C-reactive protein. Here at Mission Hospital, how I utilize PCT as part of my comprehensive Surviving Sepsis Campaign initiative, I actually looked at it quite thoroughly. I looked at the first 109 patients. I actually did 20 patients under the radar before I released procalcitonin. We did a study, and I'll talk about that after if you want more details on that. But I did a quick check of 109 patients, and for me, this is only my experience, I had 77 that correlated with not only the diagnosis but also blood cultures. So the negative PCTs had negative blood cultures, positive PCTs had positive cultures that related with diagnosis. So I had to be on the protocol, have an actual intensivist diagnose the patient, and have a discharge diagnosis. 35 correlated with diagnosis, but not necessarily blood cultures. We know as clinicians that many of our sepsis patients do not have positive blood cultures. So I was interested to find out in terms of bacteremia and PCT. 35 of those 109 actually were diagnosed with an infection and sepsis, put on our protocol, and discharged with a diagnosis of sepsis, but had negative blood cultures. Those patients also had either blood cultures from the sputum, blood cultures from the urine, they were C. diff colitis, they were perforated bowel with peritonitis, but they didn't have positive blood cultures. But those patients did have positive procalcitonin. So let's clarify. They have positive procalcitonins, positive respiratory cultures, urine cultures, C. diff colitis, perforated bowels, and there were other cases in there. But those were the sepsis patients with positive other cultures and a positive procalcitonin, but negative cultures. Then I had 7 that were all over the place. 4 of them had high procalcitonins, but were end-stage liver disease and not septic. 3 were cancer patients with an assumed neutropenic sepsis, but didn't have positive cultures. So that's kind of my little personal experience I just wanted to share with you. And I did relate that to my physician and nursing staff. We also wanted to make sure that you realize that it is endorsed here by the IHI, the IDSA, and the Society of Critical Care Medicine as one of the variables for diagnostic criteria to help with the diagnosis of sepsis. So I wanted to do a quick case review for you. This is a patient I had about a year ago. He's a 30-year-old male. He was a fourth-year medical student from the East Coast during clinical rotation at a local medical school. And I just want a quick disclaimer. I'm not making recommendations for care here. I'm only sharing my personal experience. This patient, in terms of EMS, he was brought to the ED via ambulance after a grand mal seizure in the doctor's office. He was pale, ill-looking. He had a fever of 102.4. He was tachycardic. He had a high respiratory rate, and his blood pressure was 80. He had shortness of breath, a heavy chest, and general malaise, and he had a 2-week history of a productive cough. He was on Advair and Accutane, and he had no significant medical history. He had decreased breath sounds on that left lower lobe. His SATs were 80% on 100%. He, again, in the ER was tachycardic, tachypnic, and he had hypotension. In terms of labs and radiographs, he did have a lactate point-of-care testing, BMP, CBC, PCT. We drew blood cultures and did a chest X-ray. While in the ED, he had emesis ×3 with an associated decreased level of consciousness and another possible seizure. They did call a code. He looked that bad that they actually called a code in the ER. He had decreased respirations, and he had hypotension. So off to CAT scan he went because they were trying to find out, again, what those seizures were all about. The lab results showed during that time that his PCT was 26, His white cells were 18 with 25% bandemia. His bicar was down to 19, so we know he needed fluid. His head CT was negative, and his CT of the chest did show a left lower lobe infiltrate. This is his chest x-ray, and there is that left lung infiltrate. And what that looked like on the CAT scan, there's his lung CT. It was done with that contrast, and you can see that big pus pocket, that left lower lobe infiltrate. It's very apparent, of course. So there's his big pus pocket. Those are those white cells that have gone, done their job, and died. So we diagnosed him with community-acquired pneumonia. And in terms of our 6-hour bundle element, we did actually hit all of our goals. He had his lactate screening. We did that Q6 hours times 24 hours, then Q8 times 2, and it did normalize quite nicely. His PCT was repeated the next morning, and it went down to 2.5. His blood cultures were drawn before antibiotics. He got his broad-spectrum antibiotics based off our antibiogram, so he got Benco and meropenem, and we do that by location. So whether it's neuro, skin and soft tissues, lung, bowel, that type of thing, we do guide our antibiotics based off location of possible infection. And then in early goal-directed therapy, all of our goals were met. He got 4 liters of saline in the ED. He did start off with some dopamine, although we're using more Levofed these days. His CVP was greater than 8 in 6 hours. His CVO2 was greater than 65. His mean arterial pressure was over 65, and his crit was up, and source control was not required. In terms of the 24-hour bundle element, we did meet his goals. He was on a 6-hour ACUTE protocol, and we did achieve glycemic control. He was not intubated. Zyger's administration began within 8 hours because he did have greater than 2 organ dysfunctions, and his pressors were required post-fluid resuscitation. We ran at 96 hours with no side effects noted, and he did get steroid administration because he was pressor dependent. And we don't do our ACTH DIM tests here, by the way. The PCT trended QAM, and it reduced to baseline within 2 days, which to us indicated the efficacy of our empiric antibiotic choices, and he did not have a bump up, which to me would show a secondary infectious complication. So at date of discharge, he was ambulating well with mild weakness. His quality of life was maintained. He went back to being a resident. He was discharged with Levaquin and a regular diet, activities tolerated. He followed up in 3 weeks and did get a chest x-ray, PE, and lateral. So I think the bottom line is, and I love this, in healthcare, work processes are seldom specified. Our systems are really simple, and we seldom use a scientific method for improving our processes. My job here at Mission and at my previous facility was critical care performance improvement, and it's only through a very defined, algorithmed approach can you turn a good program into a great program. So here's my little quality management hat I'm putting on now. Certainly, if you look at the bottom, we must have an organizational consensus that severe sepsis must be managed early and aggressively. We have to develop early triggers and tools. We have to implement a very excellent sepsis bundle initiative, and you have to measure success. I am a data fanatic. I collect over 30 data elements specific to sepsis. I love collecting data for sepsis. So let's talk about the deliverables for a comprehensive surviving sepsis campaign initiative. Now in the ED, we have to set up SIRS criteria for triaging sepsis. You have to find a way to initiate the early goal-directed therapy, and you have to somehow improve throughput, because we know early goal-directed therapy can be difficult for the ED. We have to not only do education for the nurses, but for the physicians, and we do CME here at both my hospitals, as well as yearly mandatory 1.5-hour education on sepsis, mandatory, just like ACLS and BLS, because it is our #1 mortality risk at our hospital. In terms of labs, ensure that your lactate, we have point-of-care testing in the ED as well as regular lactate drawn from the lab on the floors. And procalcitonin, we have currently at our mothership hospital, and we do have a smaller hospital, Laguna, that they actually have to drive up the procalcitonins to this hospital. It's about 20 minutes away. But our turnaround time is only 40 minutes, just like a basic metabolic panel. It only runs in 20 minutes, but the time it takes to run and get down there and be resulted. And it's imperative that you really encourage the manual differentials on those CBCs to look at bandemia. So that is kind of our sepsis panel that we use. We have an EMR high alert report that the rapid response nurse actually looks at, and I'll show you an example of that in a moment, and a very good, strong policy, procedure, and guideline for the entire initiative. The ED or ECU and critical care order sets, as well as a med-surg order set, and data collection, monitoring, analysis, looking at local, regional data comparisons, and then looking at your 6 and 24-hour bundle effectiveness testing. We do have the rapid response team that's fully integrated. It's a proactive initiative. They actually seek out infected patients and those that have a positive sepsis screen, and then you have to look at their empiric antibiotics recommendations. Our rapid response nurses actually go to all positive sepsis screens. Our bedside nurses are expected through the EMR to screen on every floor, every patient, every shift for sepsis. And if they have a positive screen, the rapid response nurse goes to the bedside and will order a lactate, a PCT, and a manual diff when they go. They also do go to the ERs for all code sepsis. We also have this information track and trigger system. We pull what we call high alert or high risk physiologic variables. It's not only for sepsis, but it's for other indicators as well. And so it looks at BP min, BP max, SAOC min, pulse max, etc. Anyone that's on electronic charting can do this. So our RRT nurses actually run this report, look at how many red flags, and then from there they can proactively round on the patients that they think are high risk for deterioration. At Mission, these are just some of my data, but I have many more data. Our median ICU length of stay has been reduced by 1.5 days. Our median hospital length of stay was reduced by an additional day. Our mortality reduction was statistically significant from 30 to 16%. Our acute renal failure rate requiring dialysis has been reduced from 18 to 12%. That is not statistically significant, but you know what? For each patient, it matters. And for acute respiratory failure, our rate has been statistically reduced from 58% to 35%. So the earlier you recognize them, the more aggressively you treat them, the less they get intubated. And my N numbers on that, I have 57 in my baseline data, and I have 275 in my post-implementation data. And while I say 57, I did a full year's data that showed that 30% mortality rate that had 365 patients initially. But in terms of looking at the renal failure and respiratory failure and all that, I did a drill down with only a convenient sample of 57. This was Manny Rivers' post-early goal-directed therapy analysis that he did. And Hoag Hospital is on here. That's included in these data. That's where I worked previously. And all of these hospitals to the right provided Dr. Rivers with his data. He aggregated them, and he showed that basically the summary of centers that he was involved in with early implementation showed that statistically significant improvement. And the take-home message here is you only have to do this initiative 5 times to have one unexpected positive outcome. So I think that that's so exciting. It's certainly worth our time and energy, and our patients deserve us being able to do this. Here are my basic core reference articles, and that's really it.
Thank you so much. On behalf of bioMeriU and all the attendees today, thank you for that excellent presentation.